Hello, everyone. We are pleased to have you join us for the second annual Cardinal Health Lab Exchange. Welcome to today's live broadcast, DC Healthcare Update for Laboratorians. I am Judy O'Rourke of LabRoots, and I'll be your moderator for today's event. Today's webcast is presented by labroots.com, the leading social media site for science professionals, and sponsored by Cardinal Health. Cardinal Health improves the cost-effectiveness of healthcare. We help pharmacies, hospitals, and ambulatory surgery centers, clinical laboratories, and physician offices focus on patient care while reducing costs, enhancing efficiency, and improving quality. We operate the nation's largest network of radio pharmacies, and with nearly 100 years of experience, Cardinal Health provides medical products and services to many of America's most prestigious medical institutions. In fact, most U.S. hospitals use our products and services to provide care for their patients. Cardinal Health continues to evolve, applying vast resources, knowledge, and healthcare expertise that allows us to create value in a dynamic, evolving industry. This understanding of what's next empowers us to make a difference for customers, patients, manufacturers, and healthcare partners across the continuum of care. Before we start, there are a few instructions. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, and to get your credits, click on the button located in the bottom left-hand corner of your web page. We want to hear from you during this interactive broadcast, so please ask questions or leave us a comment. Answers are welcome too. You can do this by hitting the green Q&A button at the lower left of the presentation window and typing in your comments and questions. We'll try to get to as many as we can, and we'll follow up if we don't have time today. Want a better look? You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you can't hear or see this presentation properly, let us know by clicking on the support button on the top right or use the Q&A button. We'll make sure we try to resolve any issues. Now let's get right to today's presenter. We are proud to welcome Michael Beebe, Partner and Senior Vice President at AbbVie. Michael Beebe advises clients on all aspects of reimbursement and strategic policy planning, including specific coding strategies in the physician office, the hospital, and other sites of service. Mr. Beebe also works with clients on the evidence requirements needed to secure reimbursement and approaches to obtaining the desired levels of payment for the physician, the facility, or the laboratory test. Prior to joining AbbVie, he was at the American Medical Association for 14 years. His most recent position was Director of CPT. He was a central participant in AMA advocacy efforts involving public and private coverage, coding, and reimbursement issues, including provider class action litigation, CMS physician payment negotiations, and local coverage determinations. Mr. Beebe's complete bio is found on the LabRoots website. I will now turn the presentation over to Michael Beebe.
Thank you very much. I'm pleased to be talking today about DC Healthcare Update. I'm going to be running through several of the activities going on in Washington, D.C., policy, regulation, statutes that have occurred over the past year to bring everyone up to speed. This is going to be a fairly general presentation because there's a lot going on, but I will get into some specifics when I start to talk about the PAMA regulations that came out a couple months ago, and then also about the MACRA, the Medicare changes to Medicare physician payment for physicians. So let's get started here. Go on to the next slide, overview, and then the following slide, which is DC activities in the past year, is the title of that slide. And I should probably apologize right off the bat. I had some internet issues. So they're going to be moving my slides for me. Do it the old-fashioned way. So again, I'm going to be talking about past and possible legislation, and then also some old, new, expected regulations. So in the past legislation, I'm going to be talking about the Medicare device tax suspension for 2 years, and then under possible legislative changes, talk a little bit about 21st century cures, the congressional interest and action around FDA regulation of LDTs, and then under old and new expected regulations, talk about the existing regs for the Medicare physician fee schedule, the outpatient prospective payment system in ambulatory surgery centers, the clinical lab fee schedule, and then inpatient prospective payment system regulations. And then the new or expected new regulations, what just came out from MACRA, the proposed rule to implement the MACRA regs, the changes to physician payment, the PAMA proposed rule. The final rule, as many know, has been delayed, and that's much anticipated. And then we'll talk about LDT guidance and how final guidance has been delayed a little bit, and obviously connect that back to what might be going on in Congress there. So go on to the next slide, where we're going to talk about past and possible legislation. The first topic here, slide number 5, is the medical device tax suspension. Just as an overview, on the medical device tax, slide 6, the tax itself is expected to raise approximately $30 billion over the course of 10 years. It's a 2.3% medical device excise tax. It's in effect for sales after December 31st, 2012. It was included as part of the Affordable Care Act. It was intended as an offset to help pay for the Affordable Care Act. The U.S. Treasury audit found that the tax in the first half of 2013 raised approximately $913 million. It's not a very popular tax, and there's been several attempts to repeal the tax, including votes to repeal the entire Affordable Care Act in the House, several House bills to repeal the device tax, and a bipartisan non-binding repeal of the tax in the Senate. So recently, the Consolidated Appropriations Act of 2016 and accompanying tax extenders package suspended the 2.3% medical device tax for 2 years, beginning January 1st, 2016, through December 31st, 2017. This 2-year moratorium is expected to cost less than $4 billion, but unless further action is taken, the tax will become effective again after December 31st, 2017. So basically in 2018 it will pick up again. 21st Century Cures. This has been around for the last couple years. The intention of 21st Century Cures is to develop and accelerate the discovery, delivery of life-saving, life-improving therapies, and transform the quest for faster cures in the healthcare system. So broadly, the 21st Century Cures plans to achieve these aims by removing barriers to increase research collaboration, incorporate patient perspective into the drug development and regulatory review process, measure success in identifying diseases earlier through personalized medicine genomics, modernize clinical trials, remove regulatory uncertainty for the development of new medical applications, provide new incentives for the development of drugs for rare diseases, help the entire biomedical ecosystem to coordinate more effectively to find cures faster, and invest in 21st century science and next generation investigations. The 21st Century Cures Act, going on to slide 10, passed the House of Representatives last July, July 10th, 2015, but the bill has stalled in the Senate. It really hasn't gotten anywhere in the Senate. This past spring, the Senate Health, Education, Labor, and Pensions Committee reviewed and passed a series of smaller biomedical innovation bills that share the goal of H.R. 6, which was the 21st Century Cures Act, but they're a package of smaller bills, not one all-encompassing bill. The Health, Education, Labor, and Pension Committee Chairman Lamar Alexander indicated that some of these issues will be brought out of the committee to be addressed in the Senate floor later in this session, but they also want to include the oversight for laboratory developed tests. So let's talk a little bit about congressional action around the FDA proposed LDT regulation. So there's been significant debate over the FDA's authority to regulate LDTs. A lot of stakeholders have written in to the FDA, to Congress, to the President about this authority. Congress has showed a great deal of interest. So on the House of Representatives side, the Energy and Commerce Committee circulated a discussion draft bill in October of 2015 that keeps or maintains the risk-based framework that the FDA originally initiated for regulating in vitro tests, but creates new separate in vitro center within the FDA with the authority to regulate in vitro clinical tests as a separate product under the FD&C Act. In addition, the Energy and Commerce Committee held a hearing in November of 2015 on the regulation of lab-developed tests, where CMS, Centers for Medicare and Medicaid Services, and the FDA both testified. The Appropriations Committee included report language that accompanied the fiscal year 2017 Agricultural Rural Development Food and Drug-Related Agencies Funding Bill, and the funding bill directed the FDA to cease work on its LDT guidance. So you see two different committees are taking somewhat different approaches to this on the House side. In the Senate side, the Health, Education, Labor, and Pension Committee met with the Association for Molecular Pathology, which is a professional association, to discuss the proposed modernized CLIA regulations. The CLIA regulations that are actually administered by CMS are seen as a possible alternative or different approach to achieving the risk-based framework that the FDA had proposed. While not included in Biomedical Innovations bill that was marked up by the Health Committee, LDTs could be debated on the Senate floor, as mentioned by Lamar Alexander. So I think everybody's paying a lot of attention to what might happen in this next upcoming Senate session. So looking at some of the older expected regulations that are traditionally coming out over the course of the next several months, let's talk about the payment rules. So going on to slide 15, for anybody that pays attention to all these different payment rules, this is the normal course of events, if you will, to update the physician fee schedule, hospital inpatient, hospital outpatient, clinical lab. So on the physician side, the proposed rule is expected in early July. And this proposed rule will actually be somewhat different than past proposed rules. In the past, on the Medicare physician fee schedule, new and revised CPT codes always came out, prices always came out in the final rule. This year, for the first time, new and revised payment amounts will come out in the proposed rule. It actually makes more sense that way because they are being proposed. And that's due out in early July, usually around the time of July 4th weekend. The final rule then traditionally is expected at the beginning of November, and those, of course, will be implemented on January 1st, 2017. For the hospital outpatient system and the ambulatory surgery center system, the proposed rule there is also expected in early July, with the final rule around November 1st. Implementation there will also occur January 1st, 2017. The overall theme for the last several regulatory changes in the HOPS payment system has been the continuing packaging initiative of comprehensive APCs, and most observers expect that that's going to continue in this upcoming proposed and final rule as well. For the inpatient prospective payment system, the proposed rule was just published April 2016, and the final rule for the inpatient prospective payment system is due out in August. For the clinical laboratory fee schedule, and this is in advance of PAMA, which I'll be talking about in a little bit, but the clinical laboratory fee schedule, the public meeting date has been set for the whole process of crosswalk and gap fill for new clinical lab tests. That date is Monday, July 18th, 2016, and CMS did publish the list of new laboratory tests that are going to be priced through that process. The final pricing schedule then is expected, as it has traditionally come in September, prior to implementation on January 1st, 2017. Moving on, we're going to talk about the PAMA Act and the PAMA proposed rule that came out just at the end of last year. So this brief background to catch everybody up to speed on PAMA. This is Section 216 of PAMA. It includes extensive reforms of the clinical laboratory fee schedule. These reforms include a new reimbursement framework that would base Medicare payment rates for laboratory services that are on the clinical lab fee schedule on private payer rates that are reported to CMS by applicable laboratories. So starting, theoretically, I should say, starting January 1st, 2017, most rates on the clinical lab fee schedule will be derived from private payment amounts that are reported to and tabulated by CMS for those laboratory services. Designating certain tests as, the PAMA also designates certain tests as advanced diagnostic laboratory tests. And I'll go into that definition in a little bit. But these advanced diagnostic laboratory tests have different data collection, reporting, and policies associated with them that we'll be discussing. PAMA also has certain provisions that affect coding and coverage and oversight of the clinical laboratory fee schedule. So the payment for the new advanced diagnostic laboratory tests for any test that is labeled as an ADLT are paid using their actual list charge. So the laboratory can, for the first 3 quarters on the clinical lab fee schedule, they can charge their list charge for the actual test, the ALDT test. After the initial period, payment is then based on the weighted median private payer rates that are reported by the laboratory to CMS for that new ALDT. And then the fee is revised for the ALDTs every year based on the median of commercial payment rates. For non-ALDT tests, new tests are still going to be paid based on the crosswalk or gap fill methodology until they are updated based, again, on median of commercial payment rates. For non-ALDTs, those tests will be revised every 3 years instead of every year as they are with ALDTs. So in general, the payment amount for a test on the clinical lab fee schedule furnished on or after January 1st, 2017 will be equal to the weighted median of the private payer rates determined for that test. But I think things are shifting, as we'll discuss here in a moment, and the implementation date is likely to be pushed back. So going on to the next slide, PAMA statute requires final rulemaking to be completed by CMS by June 30th, 2015. Well, that didn't happen. CMS did not release the proposed rule until the September 25th of 2015, so they were behind schedule. And then, going on, they're still not even released the final rule yet. So I think the deadlines have definitely slipped. But let's talk a little bit about what was in the proposed rule, because there are some changes that are a little different than what most observers expected based on the statutory language. So CMS does not expect hospital laboratories to meet the definition of applicable laboratory under the PAMA regulations. So this is on slide 20. CMS defines a laboratory as an entity that is defined in regulations under CLIA. So the Clinical Laboratory Improvement Act is going to shape the structure of what a defined laboratory is. Further, all labs that are paid less than $50,000 a year based on tests on the CLFS are excluded from being an applicable laboratory and thus from reporting private payer data. So they would not have to report the data under PAMA. Labs report applicable information by taxpayer identification number, and only taxpayer identification numbers receiving more than 50% of the Medicare revenues from either the clinical lab fee schedule or the physician fee schedule would be considered applicable labs. And so this would actually exempt most hospital laboratories from meeting this definition. Going on to the next slide. So these are some other proposed definitions that CMS has put forth in the proposed rule. So this is the PAMA statute in terms of defining what is an advanced diagnostic laboratory test. The PAMA statute says, what came out of Congress, says that an ALDT is a laboratory test that's covered under Medicare Part B, offered and marketed only by a single laboratory, not sold for use by a laboratory other than the originating developing laboratory or successor owner, and it also needs to meet the following criteria: that the test is an analysis of multiple biomarkers of DNA, RNA, or proteins combined with a unique algorithm to yield a single patient-specific result. Also that the test is cleared or approved by the Food Drug Administration, or that the test meets other similar criteria established by the Secretary. So in the proposed rule, CMS changed this slightly. So CMS is proposing that an ALDT must be a molecular pathology analysis of multiple biomarkers of DNA or RNA. They've completely left off the protein component that was in the PAMA statute. And they also say that it yields a result that predicts the probability an individual patient will develop a certain condition or respond to a particular therapy or therapies. It also provides new clinical diagnostic information that cannot be obtained from any other test or combination of tests. So as you can see here in the proposed PAMA rule, CMS is, I would say, pretty significantly changing the definition of an ALDT that has actually came out of the PAMA statute. So everybody is greatly anticipating what might come out in the final rule in that regard. PAMA also contains several coding provisions for when new codes need to be developed and the process for developing those codes and who would control those codes. So some of which are that CMS must assign a unique HCPCS code for existing ALDTs and existing CLDTs that are cleared or approved by the FDA if they have not already been assigned a unique HCPCS code to publicly report the payment rate. And again, this is all to uniquely identify it so you can capture the payment information that's coming from commercial plans. CMS must assign temporary codes for certain new advanced diagnostic lab tests or non-advanced diagnostic lab tests that are cleared or approved by the FDA. A lab or manufacturer of a test kit may request a unique identifier for an ALDT or a test that's cleared or approved by the FDA for purposes of tracking and monitoring the laboratory services. So in the proposed rule, CMS proposed the creation of G codes to identify new and existing advanced diagnostic lab tests and new CLDTs that are not ALDTs, but those that are cleared by the FDA. So I think this is another area where there's a lot of expectation about how CMS might further develop the coding process in the final rule. The AMA and the CPT editorial panel have put forward their own approach to this. McKesson, who develops the Z codes, have put forward an approach as well. And there's lots of anticipation about what's going to happen in the final rule to provide these unique HCPCS codes for ALDTs or for FDA-cleared tests. The timeline of the rule, which as I said is slipping, so the initial data collection period was established by CMS to be from July 1st, 2015 to December 31st, 2015, so the last 2 quarters of last year. January 1st, 2016, and then through March 31st, 2016, reports were submitted to CMS for determining 2017 clinical lab fee schedule payment rates, and CMS developed an infrastructure to allow them to collect that. And the annual laboratory public meeting for new tests does occur in July. As I mentioned before, it's going to be July 2016. And CMS is still going to use that meeting for crosswalking or gap-filling rates that are not advanced diagnostic laboratory tests. Because as I mentioned, if you're an ALDT, you do have the ability to set your own payment rate for the first 3 quarters. September 2016, CMS publishes the preliminary rates for either gap-filled or crosswalked. And then November 2016, CMS will publish the final CLFS rates for the calendar year 2017. And then those rates then become effective on January 1st. There is a significant delay in the proposed rule that's going to create a tricky schedule for CMS for the data collection period, which is actually at this point going to set to begin before the release of the proposed rule. So there's lots of unanswered questions. This delay, coupled with scheduling constraints and several other concerns, not the least of which are all the coding issues that are unresolved, as well as the definition of an ALDT, has many stakeholders calling for a delay, and members of Congress have also written into CMS asking for a delay in the PAMA implementation of PAMA. So that remains to be seen what's going to occur there. Moving on to slide 24, we're going to talk about MACRA, which stands for the Medicare Access and Chip Reauthorization Act. And this is a proposed rule that we're going to be talking about that CMS came out with about a month and a half ago, to talk about how they're going to implement the MACRA regs. And this is the changes to physician payment. And this is a pretty complicated slide, but the gist of which I think can largely be gained if you look at the graph within that dotted box. So the benefit of the MACRA legislation was that it repealed the old SGR formula, the Sustainable Growth Rate formula, which every year had a compression factor on the Medicare physician fee schedule. And the solid red line represents what that baseline would be. And you can see there that it's a pretty dramatic dip. If Congress had not intervened and passed MACRA, physician fees on the whole would have went down considerably from the baseline, would have went down by more than 20%, and then would have kind of slowly crept back up after that initial hit over the first 2 years. But as a result of MACRA and some of the changes that MACRA is putting forward, such as the MIPS plan and the alternative payment model plan, will allow physicians to recoup and actually get additional payment from Medicare by either participating in an alternative payment model or to submit performance measures and quality guidelines to CMS. And so you can see there at the highest level under MIPS, a physician at the highest performing level, exceptional physicians, would be in store for a pretty handsome bonus if as again, just for the exceptional performing physicians. And this is in theory if you meet all the requirements. So beginning July 1st, July 2015 through 2019, MACRA is going to adjust the existing conversion factor by 0.5%, but then beginning in 2020, it's going to be flat. So 2020 through 2025, the conversion factor will be flat. 26 and beyond, it's going to creep up a little bit. You get a 0.25% boost unless you're participating in an alternative payment model, and then you'll be eligible for an additional 0.5%, so a 0.75% boost. But it does establish the new physician incentive payment programs that we're going to be talking about here in a little bit, and that the proposed rule recently came out on. So the next slide, slide 26, is a timeline that talks about how this is going to be implemented over time. So over time, the incentives for physicians to control costs increase. 2017 marks the transitions to physicians being held more explicitly accountable for controlling beneficiary overall care costs. 2016 is the last year that physicians can participate in the kind of existing physician quality reporting system, value-based modifier system. 2017 is a transition year it's the first performance year for the new MIPS or APMs payment, where they have incentives penalties still reflect performance based on the old PQRS or value-based modifier measures. Not all physicians will be participating in the value-based modifier component until 2018, because that did not affect all practices. Beginning 2019 and moving forward, the merit-based incentive payment system, which is the MIPS, and the alternative payment model will kick in, and there'll be penalties/incentives to affect providers participating in those approaches, payment approaches, beginning in 2019. So going on to tab or slide 27, implementation of these programs is expected to further CMS's efforts to move away from a fee-for-service payment system and to begin to pay for value. But as we all know, the devil is in the details here. So initially, as I mentioned, it's going to consolidate the value-based modifier, PQRS, electronic health records, meaningful use. It's going to stabilize physician reimbursement. It's going to create these new incentive pathways. So let's talk a little bit in the next slide about the timeline to MACRA implementation. And this is both from the proposed rule on MACRA, as well as what was in the statute, obviously. So the fee updates you see on the top line there, and you can see what's going to happen with the overall fee schedule updates, how it's going to increase a little bit, taper off to nothing. And then beginning in 2019, the MIPS and alternative payment models begin. The merit-based incentive payment program for doctors treating Medicare beneficiaries doctors will have to participate in either of these paths, either the alternative payment model, where they would participate in an ACO type plan, accountable care organization type plan, where there is some sort of risk share. And CMS does go on to talk about risk share, and I'll address that a little bit in a moment. Or physicians need to participate in the merit-based incentive payment system. And under the merit-based incentive payment system, you can see here that they have, over the years, they have different rates of either bonuses or penalties, depending on the extent to which they are able to meet the merit incentive payments. So those incentive payments in this small pie chart here are broken down. 15% are clinical practice improvement activities. 30% of the incentive payments or the merits are based on quality of care. 30% are on resource use, and then 25% is going back to kind of the old meaningful use measure for electronic health records. Going on to slide 29. Drilling into MIPS a little bit more in some of those categories under MIPS, you can see that the distribution of those changes slightly over the years. but the performance category weights for 2019, 2020, and 21 plus begins in 19 with a greater emphasis on quality, slightly less emphasis on resource use, moving on to decreasing emphasis on quality, increasing emphasis on resource use, to the point at which in 2021 forward, resource use emphasis is at 30%, quality down to 30%, advanced care information at 25%, and clinical practice improvement activities 15%. So you can see a shift, I guess you could say, away from quality to emphasis on resource use. This is of concern to many, particularly in the provider community, obviously. Going on to slide 30, this again is looking at a timeline, but the intention here is to show that all the different pieces that need to fall into place for successful implementation of MACRA. And so far, CMS seems to be on target with the deadlines, but for 2016, the integration of Medicaid claims data into physicians so that they can compare. The comments are due to CMS on the draft plan for major development. That's March 1st that occurred. April 16th, the Secretary of Health and Human Services needs to clarify how consumers are protected. May 1st, final major development plan is due from CMS, and so far these have all been achieved. Study to Congress from HHS on the integration of the alternative payment models into Medicare Advantage plans. And then November 1st, the criteria for APMs, the Alternative Payment Models Advisory Panel, due from HHS, and the final list of initial MIPS measures, quality measures, are due from CMS. So we'll see if they continue to meet these. So early indications are that the MIPS final rule is possible that it could be delayed beyond November, which might delay implementation of the MIPS and the APMs. The final, as I mentioned, the final rule's out. The proposed rule's out. Comments were due on that, and CMS right now is deliberating on those comments, and I suspect getting lots of visits from physician specialty societies. Moving on to slide 31. So we're going to talk a little bit about defining cost quality measurement for physician payment. The current quality measures are primarily focused on process, where there's appropriate assessment, management of chronic conditions, appropriate screening of preventive care. And the idea here under MIPS is they want to develop additional cost measures, primarily focused on episodes of care and total per capita costs. So there's going to be Medicare spending per beneficiary, total per capita cost for Medicare beneficiaries, and total per capita cost for beneficiaries with specific conditions. And CMS is developing episode groupers to help enable this data collection. As I mentioned, the measures right now are primarily process-driven, but CMS requires that clinicians report at least one outcome measure and one cross-cutting measure for a total of only 6 quality measures. And so this is going to be, I think, a real challenge for a lot of clinicians to be able to achieve what they need to achieve. Talking a little bit about the episode groupers on the next slide, those are intended to hold specialty providers accountable for cost. So CMS has proposed the use of episode groupers in the resource use measurement. Each episode is defined by a triggering event or diagnosis, rather than including all the costs occurred during a specific time period. The EGM is going to include aggregates of services and associated costs identified as clinically relevant to the triggering event in the cost calculation. The episode groups were proposed by CMS for 41 clinical conditions for example, cardiovascular, GI, respiratory conditions. Expectations for physicians under the MIPS program versus the APM, and in terms of who is which physicians are expected to participate in which model. The AMA and others, the American Medical Association, other physician groups, have exerted significant pressure on CMS to include one-side risk accountable care organizations as APMs. CMS has pushed back, and CMS has proposed inclusion of only two-sided risk APMs to serve as the advanced APMs, through which clinicians could avoid the MIPS penalty. Which means that you have to participate in either APMs or MIPS. If you're in a single-sided APM, then you need to participate in MIPS. And you would be penalized then if you do not, is the idea here. It's somewhat more strict than the AMA and the physicians want at this point, and I think we're going to have to see how that plays out in the final rule. By excluding ACOs and steering APMs toward models with true downside risk, it leaves the majority of physicians who will likely be participating in in the MIPS program until there are more qualifying APMs that can be developed. So we'll have to see how this plays out, but excluding one-side risk ACOs would ultimately create stronger incentives for physicians to pursue improved cost, quality, or outcomes. So again, CMS, going on to the next slide, CMS has set a high bar for APMs to qualify as advanced APMs. To avoid a MIPS, you need to participate in the advanced APMs. So clinician must take on a marginal risk rate of at least 30%, take on a total potential risk of at least 4% of expected expenditures, and record over 25% of Medicare revenue through the advanced APM. As a result of these, this pretty high bar, it's expected the majority of physicians will participate in MIPS since the advanced APMs are not fully developed. There are only 5 existing APMs that meet CMS's criteria, and there are a few options for specialty providers to participate in these advanced APMs. So CMS estimates that in excess of 600,000 to almost 750 eligible clinicians would fall under MIPS, the MIPS requirements for 2016. Only 30,000, 90,000 eligible clinicians would be able to avoid MIPS by participating in an advanced APM. As I mentioned, there are only 5 existing APMs that are considered advanced. So the existing advanced APMs are the next generation ACOs that were established in regs several months ago at this point, last year. So the oncology care model is a two-sided risk, comprehensive primary care plus, comprehensive end-stage renal disease care, and the MSSP Track 2 and Track 3 accountable care organizations. The ones that are not considered advanced APMs are the Part B drug payment model, which was just delayed by CMS, the one-sided risk ACOs, and Medicare Advantage plans, as well as the oncology care model that's based on one-sided risk. So CMS is really pushing hard for two-sided risk in the advanced APMs. If you haven't got the idea yet, the advanced alternative payment models are an area of key stakeholder interest. CMS is taking a variety of input from Healthcare Payment and Learning and Action Network, the Core Quality Measures Collaborative that they've set up, and the Physician-Focused Payment Model Technical Advisory Committee that they've also set up to help inform their decision-making on this. The Healthcare Payment Learning and Action Network CMS has convened private payers, other stakeholders to provide recommendations on implementing pay for value, to understand what are the best practices for patient attribution, best practices for financial benchmarking, frameworks for population-based payment models, and that all kind of comes together. The recommendations will be incorporated into CMS's model through rulemaking and commercial payment models through contracting. The Core Quality Measure Collaborative that was recently established by CMS in America's Health, AHIP, America's Health Information Plans, and the chief medical officers convene leaders from CMS as well as AHIP in the National Quality Forum and national physician groups as well. And the idea here is to develop Core Quality Measure Collaborative to identify several core measure sets that contain standardized quality metrics for use across private payer programs. So they're trying to come up with key measurement sets in several high impact areas such as cardiology, gastroenterology, HIV, hepatitis C, medical oncology, obstetrics, orthopedics. The measurement sets are intended to inform the payment models, and ultimately CMS and private payers have agreed to incorporate these into the measurement sets for quality reporting in the Pay for Value program. Moving on, Health and Human Services has established a Physician-Focused Payment Model Technical Advisory Committee, PTAC, and the PTAC is charged with defining criteria for physician-focused payment, reviews models that are submitted, and provide recommendations to the Secretary of HHS as to whether the model should be implemented. Thus far, the PTAC has requested comments on a process for submission of physician-focused payment models, what the statutory requirements are to define the criteria, and the meetings are going to the meetings will be held public as a way of seeking additional broader clinical input. The American Medical Association hopes to use the PTAC to pressure the agency to loosen its interpretation of the advanced alternative payment models. However, the chair of the PTAC has stated that it's unclear whether the panel be allowed to act in such a role, because after all, it is still controlled by the Secretary. So moving on, slide 41, the expected regulations. As I mentioned throughout, several regulations have been delayed. PAMA, the final rule, is expected any moment now, and it's greatly anticipated to clarify some of these issues with respect to advanced diagnostic lab tests as well as coding. Final FDA guidance on LDT regulation is also expected. That's been TBD for quite a while now. The thinking is, part of many observers, that since Congress has expressed some interest, FDA has postponed that. But both PAMA final rule and FDA guidance on LDT regulations will have significant impact on the laboratory industry. Other executive activities, there's some administrative initiatives that might have a downstream impact on clinical labs. There's the Precision Medicine Initiative that came out of the executive branch. It established a public-private partnership. It was launched early last year. The aim is to leverage advances in genomics, informatics, health information technology to accelerate biomedical discoveries in the hopes of yielding more personalized medical treatments for patients. President Obama signed into law a budget agreement that earmarked $200 million specifically for the Precision Medicine Initiative. Then February of this year, the White House held a Precision Medicine Summit where the administration announced key actions to accelerate precision medicine. Also, as you know, late last year, the Vice President announced the Cancer Moonshot. It's his intention to spend his remaining time in office working on an effort to cure cancer. In January 2016, the State of the Union address, President Obama announced a new national effort to cure cancer that is to be led by Vice President Biden. President Obama established the White House Cancer Moonshot Task Force, and Biden is going to host a National Cancer Moonshot Summit on June 29th of this year. So that's the viewpoint from Washington, D.C. I'd be happy to answer any questions. I know it was a little long-winded and pretty technical, particularly around MACRA, one-sided risk, two-sided risk, MIPS, etc., but I'd be happy to answer any questions.
Excellent presentation, Mr. Beebe. Thanks for bringing that information to us. So before we get started with all of your questions, here's a quick reminder about how to reach us today. Questions can be sent via the green Q&A button at the lower left of the presentation window. We'll get to as many as we can. While we're waiting for questions, do you have any final comments?
I do not have any final comments at this time. Just to remind you that I still do not have internet connectivity. So if you would read the questions for me, it would be greatly appreciated.
Sure. So we'll give the audience a moment to submit their questions. Okay, well, I would like to once again thank Michael Beebe for his presentation. It appears there are no questions today. I would also like to thank our sponsor, Cardinal Health, for making it possible to bring this presentation to you. This is an educational webinar and thus offers free continuing education credits. After the webinar is over and to get your credits, click on the button located on the bottom left-hand corner of your web page. Today's webcast will be available for on-demand viewing through September 30th, 2016. You'll receive an email from us alerting you when it's available on demand and posted on labroots.com. You are welcome to forward this announcement to any colleagues who weren't able to join in today. Thanks for logging on and participating in today's broadcast. And don't miss the next webinar, Inspectors at Your Door, Is Your QC Ready?, presented by Therese Wolek and sponsored by Bio-Rad. Hope to see you there at 2 p.m. Eastern Time.
Thank you. Take care.